Hello, and thank you so much for joining us today for the webinar Sinus Sleeve Procedures in the Daily Practice. It is my great pleasure to introduce to you Dr. Daniel Rothamel, who in today's webinar will discuss the different approaches of sinus grafting procedures, the selection of different bone substitute materials, clinical and histological results, and a sufficient complication management. Dr. Rothamel is a 2007 graduate of medical school Heinrich-Heine University in Düsseldorf, Germany. He received his Dr. Med. Dent degree with magna cum laude in 2004, his PhD in 2009, and since 2007 he is specialized in oral surgery. He was a research associate in the Department of Oral Surgery at Heinrich-Heine University in Düsseldorf, Germany, a volunteer at the Clinic of Plastic and Reconstructive Surgery in Nepal, and a research associate in the Department of Oral and Maxillofacial Plastic Surgery at the University of Köln in Germany. We would like to thank botiss for providing an educational grant which made this lecture possible here today. Please go ahead and use the chat box to send your comments and ask questions during the presentation, and Dr. Rothamel will respond to all of you at the end of the lecture. And now, without any further delay, please allow me to turn it over to the expert himself, Dr. Daniel Rothamel.
So thank you very much for this nice introduction. Today we want to talk about a very nice technique to vertically improve the bone height in the posterior maxilla, which is the sinus grafting procedures. And we want to focus on clinical aspects, on scientific aspects, and also to make some techniques a little bit more clear to use it for the daily practice. We've heard already about my CV, so I don't want to introduce myself again. The research topics I'm involved in is bone regeneration, implant surfaces, cancer treatment, and today, of course, because the sinus cavity is an area where we really like to use bone substitute materials, we will focus on different bone substitute materials. What happens after a tooth extraction? Of course, we know that we see dimensional ridge alterations after tooth extraction, that we have two different parts of this mandible, for example, that we have the basement of the mandible and also the alveolar process. So when we remove the tooth, we can see that in this area, the functional loading on the alveolar process is missing. So therefore, we can see that in this area, the alveolar process is being resolved. So with ongoing time after tooth extraction, we can see that the alveolar process will just disappear to the situation where we just have the basement of the mandible. In the maxilla, it's quite comparable regarding the alveolar process. So we can see that the alveolar process is just remodeled again. So we have a vertical height loss and also a horizontal loss. But here another aspect is taking place, that also the sinus cavity is expanding, that we have vertical resorption also from the side of the sinus. So it ends up to the K-word classification number 5, where we have just a very thin bone layer on the bottom of the sinus cavity, and that makes it quite hard to place implants with the primary stability. So we need bone around the implant. We need the functional integration of the implant body, and we can see it here on this histological slide that we have a direct contact of vital bone matrix to the implant surface that is guaranteeing the long-lasting stability and also the possibility to functionally load the implant to restore the patient. So when we focus on this bone area, we can see that this bone consists of 3 different aspects of cells. On one side, we have the osteocytes, which are mainly placed inside the osteocyte lacuna. They're major bone cells, they're connected to each other. So they're not producing the bone, but they are leading to the effect that we have a vital bone matrix that might adapt to different loading situations. On the other hand, what we also see is some osteoblasts here as lining cells, and these osteoblasts are able to produce different collagen molecules, also glycoproteins that can be mineralized. So therefore, the osteoblasts are very interesting for us because they are able to produce the cells. And then on the other hand, we also have some osteoclasts, the bone resorbing cells, and depending on the loading situation, depending on the Wolff's law, meaning that we have a steady state of remodeling depending on the on the loading of the bone, we see that we either have some bone apposition or some bone resorption in different situations. So this is the already formed bone. What do we know about the bone regeneration? So what we thought 30 years ago was that when we have a bone defect, the osteoblasts that are placed here as lining cells are invading into the grafted area, starting to produce new bone. But what we found out was that the osteoblasts are very highly differentiated cells, so therefore they are not able to migrate. They lost the capability of moving from one side to another. And the cells that are able to move into a grafted area are mainly the stem cells. So bone precursor cells that are necessary for the bone regeneration. And we find these cells mainly in two different areas. One area is the stroma of the bone marrow that makes autogenous bone that interesting for grafting procedures, because depending on the grafting technique, we can maintain that these pre-osteoblasts are surviving and start to produce new bone on the recipient side. On the other hand, what we also know is that when blood vessels are invading into the grafted area, around these small blood vessels, we find a high concentration of undifferentiated progenitor cells. We call them the pericytes, and these pericytes are also able to differentiate into bone cells if they find a nice osteoconductive or osteoinductive matrix and an osteoinductive stimulus, and then they're able to start to produce new bone. We come back to the clinic, so we have different defect classifications described for different areas of the alveolar process and also of the mandible and the maxilla. And today we want to focus on the classification of Davapana in the year of 2001, where it was described that in some cases only the sinus is extended. Sometimes we see a vertically resorbed crest, a horizontally resorbed crest, and also a combination of both. And because we are talking about a non-aesthetic region mainly, we can see that sometimes we don't really need to re-augment the vertically resorbed crest, so we can just place the implants a little bit more to the apical direction, maintain that we have enough bone in this region, and then, for example, for a completely edentulous patient, we can maintain stability to support the prosthesis. So some historical aspects. The first sinus lift was performed by O'Hill Tatum in 1977, and the first lateral approach that was published was performed by Peter Boyne in the year of 1980. So he inserted some autogenous bone underneath the Schneiderian membrane using a lateral window approach. And interestingly, what he found was that the entire bone that he grafted resorbed completely again if no implants were placed. This is also based on the steady state of remodeling. So if you don't place implants, there's no functional loading on the bone, so the patient's own bone will just disappear again following the Wolff's law. So from 1988, different bone substitutes were grafted in the sinus, and with different elevation techniques, it was found that also bone substitute materials are showing predictable results alone or in combination with autogenous bone. It took some more years, but then in the recently published studies by Klein and Alnoas, there was a systematic review about the comparability of autogenous bone and bone substitute materials, and they found no difference between bone substitute materials and autogenous bone for the indication of sinus grafting procedures. So today we can say that we can maintain the same results when we use autogenous bone or bone substitute material, with the side effect that, of course, we can take the bone substitute material from the blister, whereas the autogenous bone needs to be harvested from another region. So what sinus grafting techniques do we have? Of course, we have techniques using a crestal approach, like the osteotome expansion technique, where we need just a little bit of bone, and we are using the flexibility of bone based on the collagen content. Then we can use Sammis technique, so it's called internal membrane preparation, that we perform a preparation of the Schneiderian membrane and place some bone graft material underneath the Schneiderian membrane through this crestal approach. Then different aspects of it, using a balloon lift, a hydrolift, and so on. We don't focus on this because we don't using it in our practice today or in our clinic. Then, of course, the lateral window approach, 1 and 2 stage procedures with and without implant placement. Here, the historical threshold is about 5 millimeters. So when I learned placing implants, I was told if it's less than 5 millimeter, you have to do a second stage surgery to place the implants. Of course, implant shapes have changed a little bit. Also, the implant surfaces have changed. So when we maintain or can guarantee a primary stability of the implant, we can easily place implants also in 4 or 3 millimeter remaining bone height. The only important aspect is that we have to make sure that the implant is primary stable. And then if we have a combined defect, a horizontal defect, for example, a vertical defect, we can combine it with further augmentations. So first, the osteotome or expansion technique, bone gain less than 3 millimeters, a very simple technique. For example, in this case, with a remaining bone height of about 8 millimeters, we wanted to place an 11 millimeter implant. And what we can see here is that we have enough bone to place the implant with a predictable primary stability. Of course, what we do is that we perform the preparation of the implant cavity, and then before placing the implant, we are using some flat osteotomes, and with some hammering technique, we can expand the sinus floor a little bit more to the apical part, and then placing the implant. So the idea is to use the flexibility of the bone, and we can see it quite easily on the postoperative X-ray. Then that we, with these little hammering techniques, of course, the patients don't like it that much because of this intensive hammering, but you can see in this region that the flexibility of the bone had the effect that we have expanded the bone more to the apical part. There's no need for application of bone substitute materials underneath, that we can just place the implant, leave this gap filled with blood, and we can expect that in this area we will see some bone formation. So it's not the idea that we do the preparation of the Schneiderian membrane, it's more a bone expansion or bone fracturing technique that we expand the length of the implant of up to 3 millimeters. It's also very useful when we have performed the sinus grafting and we see when we want to place the implant that the sinus area has just lost some volume, some height. Then we can just use this technique. For example, in this situation, you can see that there's a loss of the vertical height of the sinus grafting during the 6 months after the surgery. We perform this technique with some flat osteotomes. Then we can place the implant in the desired length. So also here, after 6 months, sometimes the bone graft inside the sinus cavity is not that hard, so therefore we can easily expand it a little bit to the vertical dimension, and then we can place implants of the desired length. Another technique that can be used for a very low trauma sinus floor preparation is the Sammis technique. Sammis technique means that we perform a quite comparable technique like the osteotome technique, but then at the end of lifting this bone lid up, we can perform some preparation of the Schneiderian membrane. Therefore, we are using two different types of osteotomes. You can see here a flat osteotome that is able to lift this bone lid a little bit up, and then we use blunt osteotomes to perform the preparation of the Schneiderian membrane. So in this case, for example, remaining bone height of about 4 millimeters, in this technique we can look through a endoscopic view from the view of the sinus. You can see the bone lid that is lifted a little bit, and then we use this blunt osteotome for the preparation of the Schneiderian membrane. The problem here is that normally you don't have this observation device, so sometimes you have a little perforation, so therefore it's always recommended to know about the lateral window technique when we perform this technique, but you can easily see that with some bone grafting material, we can easily place an implant in this region with an internal sinus grafting procedure. So the big advantage, of course, is that with this technique, the swelling is less than with a lateral window approach. On the other hand, when you have a lateral defect, you can't perform the lateral defect augmentation with this technique only. You have to raise the flap on the buccal aspect to place the bone graft material on the lateral aspect. Some clinical data, some scientific data about this technique published by Damir Selusic from Croatia. So he performed 100 internal sinus grafting procedures with direct implant installation with an average residual ridge of 5.03 millimeters. So he compared two groups. One was cerabone, we will focus on these materials later, and one was Maxresorb. Cerabone is a bovine bone substitute material. Maxresorb is a biphasic synthetic bone substitute material. All in all, two implants failed in each group, so therefore a success rate of about 96%. No statistical difference between both groups, with the augmentation height of 7.3 millimeters or 6.3 millimeters, and very good osteal measurements when placing the implants at the same stage. So the Crestel approach using the Sammis technique is a very predictable technique to gain bone height in vertical dimension inside the sinus cavity. We come to the most common approach to the sinus, the lateral window approach. Also, the first publication by Bone was performed using this lateral window approach. The historical threshold of about 5 millimeters. I mentioned this already. It's not longer a rule, it's more a recommendation, probably depending on your implant system that you're using. So we have 1 or 2 stage procedures, another video about the technique of this lateral window approach with placing an implant at the same stage. So we see the crestal incision with flat raising of a mucoperiosteal flap. And then sometimes what we first do is that we mark the implant position. Then we have different techniques. You can use Piezo, for example. You can also use some diamond burrs. What we are using mainly is some round burrs. If you have a high rotation speed and some experience, it's a very quick procedure and without a high risk of membrane perforation. So if the patient is not under general anesthesia, you can see that the membrane is lifting up and down a little bit, and then we use specific instruments for the elevation of the Schneiderian membrane. Sometimes what you see is that there's a little artery coming parallel to the teeth from the back area to the incisor area. In most cases, not a big problem. Just wait a little bit, then the bleeding coming from this artery is stopping by itself. So implant placement, and then this is Maxresorb, some biphasic bone substitute material that is placed around the implant, also on top of the implant tip, to make sure that we have a predictable outcome of bone formation surrounding the entire implant. Then, of course, this is an old case. There was a lot of discussion within the last years about placing an implant in this specific area. Of course, we didn't perform a periosteal incision, so therefore it was mentioned from different surgeons that there's no need for membrane application. We will see about the literature later that, of course, today we have to place a membrane even on this situation when we use some bone substitute material in direct contact to the mucoperiosteal flap. So another case, a vertical defect in the maxilla and also a horizontal defect in the mandible. as already mentioned. So when we use bone substitute materials, it's recommended to use membranes. You can either use resorbable or non-resorbable membrane. What you see here is a pericardial membrane that is quite stable with a long-lasting barrier function. We use this membrane for all our augmentation when we use bone substitute materials, because this long-lasting barrier function is leading to a very predictable outcome. So some cerabone particles underneath, and then after rehydration of the membrane is getting a little bit more flexible, is stabilizing the graft area. In the upper jaw, of course, a little vertical augmentation in this area. There's no discussion about that. This area has to be covered with a membrane to see a more predictable outcome. There's a lot of discussion in the past about this membrane that is placed on the lateral window approach. So to see whether this has an effect, of course, we need to look at high implant numbers, high sinus augmentation numbers, and there's a nice publication by Wallace and co-workers who reviewed 43 studies, about 6,500 implants. And what did he found? Indeed, you can be successful if you don't place a membrane on the lateral sinus window. So for example, in this publication, 92% is not bad, 96% is not bad, 78%, this is something you have to discuss with your patients when you want to use this technique. But one very interesting thing is that in most of the studies that are published using prospective, randomized, controlled design, that when we use a membrane to cover the lateral sinus window, the implant survival rate and also the bone outcome is significantly better than not using the membrane. So therefore, it's recommended today to use a membrane also on the lateral window approach. Also, for German surgeons, there was a statement of the German Association of Dental Implantology, the DGI, published by Professor Schliephake in the year of 2005, that in whatever indication, when we use bone substitute material, then we have to place a membrane to reduce the risk of ingrowth of undesired cells and incomplete defect fill. So therefore, whenever we are placing bone substitute materials, we have to face that the soft tissue is trying to invade into the grafted area, that we have a fibrous encapsulation of the grafted area, and to avoid this negative outcome, to increase the predictability of the graft, we can use a very simple technique following the principle of the GBR technique, that we place a membrane. Also in a quite current review of the Tano group, published 2012, they compared 10 evidence-based review about the sinus grafting procedures. The most positive outcome was also found when there was a membrane placed, a barrier membrane placed on the lateral window approach. Some other aspects, the utilization of bone replacement grafts was showing a very positive outcome, and also this is something that we all know, using rough surface implants is leading to a more predictable outcome than using the old smooth surface implants. So what bone substitute materials can be used? They're mainly differentiated regarding their immunologic origin. So we have the genogenic material, which is the bios, cerabone, for example. They're based on bovine bone. Most of them, they're deproteinized, and they consist of mainly hydroxyapatite, so natural hydroxyapatite. Then we have the allogenic material. Allogenic material is coming from human donors. They can be cadaver bone or vital donors, and we can use it in a demineralized setting or in a mineralized setting. Sometimes they're containing some osteoinductive proteins like BMP, sometimes not. Sometimes they're just working in an osteoinductive way, that they are providing a scaffold for the bone ingrowth. And then last group, the alloplastic material, the synthetic material, big advantage. We don't have to inform the patients about the background of the material, about some possible risk of infection transmission, for example. They're mainly based on beta-calcium phosphate or hydroxyapatites, and have their own advantages such as that we can specifically influence the surface, the material itself, depending on the needs or expectations that we have when we use these synthetic materials. So different bone substitute materials have different properties. Porosity is different, mixability is different, origin is different, biological activity. And when we look at the very old publication, we can see that the resolvability was asked a lot in the older publication, that the bone substitute material has to be resolved very quickly and should be replaced quite early with the patient's own bone. On the other hand, what we saw, specifically in the sinus and also for lateral augmentation and for immediate implant placements, is that a material that is resorbed very quickly has a very low volume stability sometimes. So we know from different studies about biomass that after 5 years, after 10 years, after 13 years, the material is still there, can be identified when we take a biopsy. So therefore, we can say that the bovine materials are almost not resorbable, but leading also to the effect that we have a very good volume stability when we use these materials. And we can easily see it as well when we look at these histological slides. We have some materials that are resorbed very quickly. That is the allogenic bone because it contains some collagen, and also the autogenous bone that is sometimes a vital bone matrix. These materials are showing a very fast remodeling. Then we have some materials, the synthetic materials, that are mainly integrated into the surrounding bone, and then they're showing a controlled resorption. Beta-decalcium phosphate is showing a very quick controlled resorption, whereas hydroxyapatite is resorbed very slowly. And then we see the bovine materials, for example, that are mainly integrated. Even after 10 years, when we take a biopsy, we can still find some particles, leading to the effect that these materials are showing a very, very good volume stability. And one of these materials that is mainly integrated is cerabone. Cerabone is bovine bone. It's heated up very intensively to 1250 degrees to make sure that there's no infectious agent inside this natural hydroxyapatite structure. It has a high porosity of 65 to 80%, and the idea is of this material that the resorption is very slow. It's remodeled on the surface, but it's not resorbed completely, even not after 10 to 20 years. The big difference to biomass, for example, is the manufacturing temperature. Biomass is produced with temperatures of about 380 to 400 degrees. So we have to find out whether this has a negative effect on the bone formation when we use this material for augmentation procedure that is sintered, that is produced with this temperature treatment. So this is a patient that has taken part in a study where we performed the sinus grafting procedure with biomass covered with a bioguide membrane on one side and some cerabone covered with a JSON membrane on the other side. So this is post-operative X-ray situation at implant placement. We can easily see that this smooth surface, mainly based on the long barrier function of the JSON membrane, is showing a complete osseous formation of the entire grafted area. So implant placement, another lateral augmentation, post-operative X-ray, and for us very interesting that we took some biopsies from both sinuses and we didn't see any difference. So of course the staining impression of these two materials is a little bit different, but we see nice bone formation on both bioos and cerabone particles 6 months after sinus floor elevation. There was one patient, we published a study, a case report study in the year of 2011 after application of cerabone into the sinus of 12 patients, no wound healing complications, no treatment failures, quite predictable outcome when we talk about sinus grafting procedures. And the newly formed bone was 25 to 50%, so a very nice outcome when using this material for sinus grafting procedures, and also high volume stability based on the bovine origin of this material. Another study that is ongoing in our department and some other centers, about 44 sinus lifts comparing in a randomized setting, bios and cerabone, both covered with adjacent pericardial membrane. And we are evaluating currently the Trafine code that we took in progress of implant bed preparation. So the preliminary results: one small wound descends, no negative impact on bone formation. The remaining patients are showing perfect bone and soft tissue healing, and we evaluated the first 42 bone cores and found quite predictable bone formation inside the sinus, independently whether it was grafted with bios or cerabone. The very good volume stability can be easily used as well when we have a more complex defect situation. So for example, in this situation, we expect a vertical and a horizontal defect, and when we reflect the flap, we can see a remaining bone width of about 3 millimeters in combination with a vertical bone defect of about 7 millimeters with a remaining bone height of about 5 millimeters. So we know today that we can use bone substitute material only for the sinus grafting, but when we go outside the ridge contour, it's recommended to use some bone substitute material in combination with some autogenous bone to increase the biological potency of this graft. So this is cerabone only in the sinus cavity, and in this situation, an additional graft of cerabone with 20% of autogenous bone for the lateral augmentation. Again, application of this pericardial membrane, no double layer technique or something. We know that the barrier function of this membrane is going up to 4 to 6 months, so therefore there's no need for a double layer technique. And then post-operative X-ray. Of course, we didn't equalize the vertical bone defect, but in this non-aesthetic region, we can easily place the implant in a more apical position. Situation after 6 months, reflecting the flap, we can easily see that there's a lot of bone formation on the lateral aspect, quite predictable with a smooth surface. So we see a 100% bone formation on this lateral bone graft. And then we took again a biopsy of this patient. We can see the former sinus floor and then the grafted area. And after 6 months, we can see that there's a bone remodeling on the surface of this particle, but after 6 months, there's no complete resorption of this material, and this material will remain stable for a very long time. We come to another group, integration, control, resorption of synthetic materials, and there was a study that was discussed a lot in Germany about the comparison of beta-2 calcium phosphate and autogenous bone. So what they found was that there was no difference regarding the bone outcome and the implant survival, because the sinus lift is a forward defect with very good prerequisites for bone regeneration. That was nothing new, but that was the first time that somebody concluded if we get the same result when we use bone substitute material and autogenous bone, and we need to harvest the autogenous bone from another site, then probably we should select the bone substitute material, because it's leading to less stress, to less discomfort for the patient, and for the sinus floor elevation only, this using of autogenous bone was classified as overtreatment. So a lot of discussion about this study, because we are still having a lot of doctors using hip grafts, using autogenous bone from the intraoral sites for the sinus floor elevations. For me, it was very interesting in terms of this publication that they compared autogenous bone and beta-2 calcium phosphate, and they both are showing the same effect, that it's not the most stable material. You can see 2007, the bone is on top of the implant tip, and then within time the bone is resorbing. So it's not the case that the tip of the implant is inside the sinus cavity, but we're talking sometimes about short implants. Probably in some indication we could easily place a shorter implant, because this implant tip is not longer important for the stability of the implant situation. So why is that the case? We know that bovine hydroxyapatite has a very long resorption time, whereas the allografts and autografts and also the beta-2 calcium phosphate is showing a quick resorption and a quick remodeling of this material. So the idea of the next generation of the synthetic materials is that we combine a hydroxyapatite, a synthetic hydroxyapatite, with some beta calcium phosphate. Why is that the case? Because we know that synthetic hydroxyapatite is showing a very, very good long-term stability. This is a sinus grafting after application of a synthetic hydroxyapatite. We see bone formation, but this bone formation is not in direct contact to the bone graft particle. Whereas when we compare it with some beta calcium phosphate, there's almost nothing left of this material, leading to the effect that we have a volume shrinkage. So therefore, the idea of this next generation is that we have an osteoconductive material that is integrated very quickly, like the beta calcium phosphate, but also having a long-lasting volume effect based on the delayed resorption of the hydroxyapatite. So one material provided by botiss is a max resorb. It's consisting of 60% hydroxyapatite, 40% beta calcium phosphate with very good granules. And the idea of this material is that because it's a synthetic material, that we can specifically influence different aspects of this material. So we have a very high porosity, and this is another aspect. We have a very, very rough surface. And this rough surface is leading to the effect that we have a very early attachment of serum proteins of cells, and this supports the bone formation. And this is completely different to bone ceramic, for example, which is also a material based on 60 to 40 beta calcium phosphate hydroxyapatite. But the surface is completely different to max resorb, and we see after 3 days, after 7 days, that bone cells are really attracted by this surface, and this might support the bone formation after application of these granules. So does it have a volume aspect as well? This is after application of this material direct postoperatively. After 6 months, we can easily see that it's almost like the bovine materials, that we have a very good volume stability in this situation. When we again look at a split mouth patient, one side was grafted with some biphasic material, which is max resorb, the other side with some beta calcium phosphate, which is ceresorb material, so almost same bone height on both sides. We can see that we have almost the same prerequisites on both sides. After a healing period of 4 months, in this case, we performed some implant placement, some trephine harvesting. What we see here is that on both sides, of course, we find bone formation. So whatever you put into the sinus, you can see that there will be some bone formation. But what we also see is that on this side, the bone substitute material is resorbed almost completely, whereas here we can still identify the particles. So this has a more long-term stable effect. It's not resorbed at all after 4 months. And when we look at the clinical point of view, we can see that this is leading to the effect that we have no resorption of the graft on the right side, whereas on the monophasic side we see some volume loss and also some areas where the predictability of the bone formation is not as good as the biphasic side. Again, some clinical data from Dr. Zilucic that was performed in Croatia again. Prospective controlled clinical study about beta calcium phosphate and hydroxyapatite. Healing period again 6 months. And we investigated the trephine that were taken in progress of implant bed preparation. So clinical results, 30 perforation, about 20%. Of course, we see perforations of the sinus floor membrane, not a big problem. We will focus on this a little bit later. No wound healing complication or infections, and 1 implant that was lost in the beta calcium phosphate group. So we look at the histomorphological results. So nice bone formation on both sides, so no statistical difference comparing the max resorb and the bioresorb material. But that was something that was quite interesting. As expected, we found a higher volume alteration in the beta calcium phosphate group compared to the biphasic group. A little bit of loss in this area. This is 2 milliliters going down to 1.91 milliliter, whereas here the volume reduction was more intense, leading to the effect that we have a reduction of the vertical bone height in this area. And osteum alterations about the quality of the bone. 3 months after implant placement, what we see here is that the osteoalteration were more significant in the biphasic group. That might be a result of the longer stability of this material as well, that we see a faster osseointegration of implants placed in this biphasic group. The question is, can we use this material as well for larger augmentation areas? This is a more demanding case, of course. What we can see here is a vertical bone height of about 1 millimeter. So when we perform large sinus grafting procedures like this, sometimes I prefer, or in most cases, I prefer to place a membrane even to cover the Schneiderian membrane when I don't see a perforation at all. So we know when we put a lot of granules in there, sometimes we don't even realize that we have a perforation. So one technique would be to place a membrane that we have a tent defect, and it's much easier to place the material underneath this membrane and to make sure that there's no dislocation of the material into the sinus cavity, causing some inflammations or complications. So this is max resorb only into the sinus cavity, some max resorb with 20% of autogenous bone for the lateral aspect, application of this Jason pericardial membrane, again, closure, and at the re-entry after 6 months, we can easily see that we have improved the width of the alveolar process tremendously. So what we can see here again is the effect that we have perfect integration of the bone substitute material into newly formed bone matrix. So we took 2 biopsies, placed 2 implants in this white bone that was starting with a very compromised situation. And when we compare this trephines with a trephine, for example, that was harvested after sinus floor elevation using a hip graft, we can easily see that there's a big difference of the bone quality. This is after hip graft sinus grafting procedure. We can see the remaining bone height of about 1 millimeter, and there's a vital bone matrix inside the sinus cavity, but the quality of the bone is more D3 or D4 bone. So it will improve after placing the implant and perform a functional loading. But when you compare it with the trephines we took from this patient, we can easily see that the bone quality is much better when placing some bone substitute material into the sinus cavity. But with another very interesting aspect when we compare it to the bovine bone substitute materials. So when we look at this area in a higher magnification, you can see that this particle is starting to be remodeled completely, meaning that this material is not lasting forever regarding the resorption and bone remodeling. It's more the case that this material will just disappear within 2 to 4 years probably, that after 4 years this material has turned over into vital bone matrix. So if we want to have only the patient's own bone after a long healing period, probably this material would be the material of choice for sinus grafting procedures. So we come back to this publication. We talked about the utilization of bone replacement grafts, about rough surface implants, about the application of barrier membranes, and then another further aspect that the utilization of piezoelectric surgery leads to a dramatic reduction in the occurrence of the intraoperative complications of bleeding and membrane perforation. So we're also using piezo surgery. Sometimes we use the Piezo med that was just introduced by W&H. We like this piezo device because it has a lot of power, and for example in a situation like this where we want to reconstruct both the sinus and also the alveolar process in the vertical dimension, we need to harvest a bone block from another side. So not a big problem, but the patient has a very high smiling line, so therefore we had to reconstruct the area also in the vertical dimension. So then we use this piezo med for the preparation of the sinus cavity, and then application of the bone substitute material, and then we changed the area. We went to the posterior mandible, and we took a very thin bone graft from this ramus region that perfectly fit to the recipient side. You can easily see that in this area, this is a very long and thin bone block, and with this angulated tips of the piezo meal, we can easily perform the preparation exactly like we want to graft the block in the recipient area. Not a big bone defect on the lateral aspect, but when we look from the palatal side, a large bone defect in this area. So we have a lot of stability from the bone block. So therefore, we can just use some cerabone particles underneath in combination with some autogenous bone. I think that about 20% of autogenous bone is quite enough to enhance the quality. If you put more autogenous bone underneath, sometimes you see for vertical large augmentation that the bone is not as stable as a combination of bone substitute material and the autogenous bone chips. So we change the situation to the bone substitute material. Therefore, of course, we need to place some membranes to make sure that there's no soft tissue invading into the grafted area, periosteum slitting, sufficient wound closure. And when we look at the postoperative X-ray, we can easily see that we performed a sinus grafting for vertical bone and reconstruction, and also a crestal application of a bone graft to make sure that we have also the bone in the right position to perfectly dimensionally place the implants. A few words about complications. What complications do we see? Of course, intraoperative complications, damage of the Schneiderian membrane, about 20 to 30% in most of the publications. But what we know is that these perforations have no connection to the postoperative complication, that we lose the entire graft, that we see more infections when we are able to stabilize the Schneiderian membrane using, for example, a collagen membrane. Then postoperative complications, wound infection, abscess, or descent of drainage. In this publication, just recently published 9 cases. From my point of view, quite a lot for a normal sinus grafting procedure. Also maxillary sinusitis, 6 cases. So in 200 consecutive sinus lift procedures, this is about 3% of sinusitis and 4.5% of wound infection. Also, the partial exposure of the simultaneous onlay graft in 6 cases, loss of the graft 2 cases. So we are performing a lot of sinus grafting studies, and we see a little less complication rates all in all when we perform our techniques and our bone grafting materials. Nevertheless, we can focus on the damage of the Schneiderian membrane again. You see in this case, for example, a little perforation. We know today that this is not a big problem. We can just place some collagen membrane on top of it. We can go on with our sinus grafting procedure, and then after 6 years, you see no negative impact on the implant survival rate. Interestingly, in some publications, they even lost more implants with non-perforated sinus than with perforated sinus. You can see here non-perforated sinus 160, lost implant 13, perforated sinuses 41, lost implant 1. So therefore, we can easily say that a small perforation of less than 5 millimeter is not leading to a negative outcome. So when we are able to place a membrane that we can repair the membrane perforation, then we have a secure method to avoid graft dislocation into the sinus that might cause some sinusitis or loss of bone substitute material through the sinus cavity. And again, in this study, sinus floor perforation had no negative effect on implant survival. However, when we have a perforation, we have to discuss what can we do to make sure that the membrane stays in place when we put it on top of this perforation. And for this indication, also for situations where we don't see any perforation, we published a very simple technique to make sure that the membrane is showing more stability. For example, in this situation, we can just use a large membrane because we know that we have to close probably a perforation here. We just want to make sure that this graft is not dislocating into the sinus cavity. and we called it the fish technique. Fish technique means that this diameter here is almost the same like the diameter in between these two bone walls. And the fish is folded, and the head of the fish is placed into the sinus cavity, making sure that this membrane inside the sinus is fixed and shows no dislocation when application of the bone substitute material will take place. So then, of course, very simple to place some bone substitute material underneath, and then following the recommendation of the EAO, the DGI, all the different organizations, we can just cover the lateral sinus approach with the second part of the membrane that we rehydrated, and then we just flip this membrane over, and this is fixing itself because it's fixed on the more upper part, and then we can just perform the sutures, and we are absolutely sure that this membrane is locally stable. So you won't get more bone, of course, but sometimes we like this technique to make sure that we have no dislocation of the membrane or undesired loss of material into the sinus cavity. What can happen if we have a perforation that is not realized, or if we have some material going into the sinus area, or even an infection itself of the entire graft area? This might lead to acute sinusitis. This is the worst case that can happen when we perform sinus grafting procedure. So what we see here, specifically in this picture, is the second problem that we see. We see the ostium naturalis, which is quite high, so you don't need to be afraid that you reach it when you put your bone substitute material down here. But this is the second problem, that in this infected sinus, this ostium naturalis is closed completely. So therefore, one very important thing might be that we use some xylometazoline nose drops, for example, to just reopen it to make sure that there's that the pus or the liquid is able to go out of the sinus area. So what antibiotics do we use when we look at the bacterial spectrum? Streptococcus, Bacteroides, Staphylococcus. So they're all sensitive for aminopenicillins with clavulanic acid. So we are using Amoclav 3 times 500 or 1000 milligram per day if the patient is showing some allergies. And just in this case, I would always prefer the aminopenicillins. Just when the patient has some allergies, we use clindamycin, and sometimes when we have a severe inflammation, we use the Van Winkelaar cocktail, which is a combination of aminopenicillin or clindamycin with metronidazole. And we use it in all the cases where we perform sinus grafting procedures. And the most important thing is that we have to start with taking the antibiotics before we start doing the surgery. So when we talk about perioperative sinus lift management, it's very important that when we put the material into the sinus area, then the blood of the patient should be loaded already with some antibiotics. Because if you perform the surgery, you give a prescription to the patient starts with the antibiotics at the evening, for example. Probably when you have some bacteria inside the sinus area, it might be too late and you get a severe inflammation. So therefore, we start at least 1 day or 1 hour with a triple dose before starting the surgery. Then oral disinfection with chlorhexidine or chloramine solution, of course. When we touch the gum with our instruments, we don't want to bring the bacteria into the sinus area. And then when we have a small perforation, or in our cases, when we see that the membrane is very thin, we use collagen membranes to make sure that we have no graft dislocation into the sinus by using some collagen membranes. Then after the surgery, we go on with our antibiotics for at least 1 week. Silumetazoline spray, that the ostium naturalis will remain open, and of course no nose blow for the time after the surgery. When we see sometimes that patients are coming back for postoperative control and is losing some material via naturalis through the nose, this is not a big problem. If you have performed a lot of sinus grafting procedures, you might have had a patient like this, that they are losing some granules through the nose. Not a big problem, just go on with the antibiotics and silometazolene spray, and they might lose a little bit of the material, but this is not causing massive inflammations. However, sometimes we see graft infections. This is a study by István Urban published in 2012, 2.8% of graft infections. Then it's recommended to use, of course, antibiotics, that we perform a surgical revision, but just a partial removal of the material. Sometimes when you open it, you can clearly identify the area that is showing this pus formation or the infection. Then it's recommended, following the publication of István Urban, that we just partly remove the material. When we see a massive inflammation, an uncontrolled sinus infection, a pansinusitis, for example, it's recommended to completely remove the entire graft and also the implants to make sure that we have no foreign material inside the sinus area. And then we wait at least 3 to 6 months before we redo an operation. And in these cases, of course, we would always recommend to use autogenous bone from the hip or from another intraoral sites when we do a second look surgery, that we enhance the quality of the bone graft for this second augmentation procedure. So almost at the end of the presentation, I just want to close with 2 citations from this study that I found about sinus lift procedures in general, about different current techniques. We know today that for more than 30 years, the maxillary sinus augmentation graft has been a mainstay of implant-directed maxillary reconstruction. So we have a very sufficient technique to vertically reconstruct the bone in the sinus area. And with preparation, education, and experience, the maxillary sinus augmentation or elevation graft is a procedure that greatly benefits the patient and also the surgeons with a predictable outcome. Thank you very much for your kind attention. Okay. So after the presentation, I think we have some time left for questions. The first question is asked by Mr. or Mrs. Nabidi. Do you use bovine bone graft material with autograft mixed? What we know is that when we perform a normal sinus grafting procedure with the remaining bone height of about 2 millimeters, for example, then we can use the bone substitute material only. So the bovine bone is sometimes mixed in our clinic with some autograft, when we can just see that the facial aspect of the sinus is consisting of a very thick bone plate. Then we, of course, we collect the bone material that we are removing when we are performing the lateral window approach, and then we mix it. But what we don't do is that we open another site. So we don't open the retromolar region, for example, just to have more bone for the sinus grafting procedure only. There are some studies about the ratios of autografts and xenografts. We know today that we can enhance the quality of the graft when we add some autogenous bone up to 25%. This is increasing the bone regeneration time. But on the other hand, when we can expect the same results if we wait just 2 months longer, from our point of view, there's no need for the harvesting of autogenous bone just to enhance the quality. When we have a bone height of less than 1 millimeter, of course, this is always mixed with autogenous bone. And also in situations where we have performed a sinus grafting before and somebody else has performed a sinus grafting, then we have very compromised situations. Sometimes we use autografts only just to make sure that we see a predictable outcome in this pre-operated sites. Okay. Next question is Mr. Babintsev. Do you extend the osteum before the sinus? I think you're talking about the osteum naturale. I think there's no need to extend the osteum before the sinus grafting procedure. What we do sometimes is when we see that there's a very thick schneiderian membrane, that we perform a three-dimensional X-ray, a cone beam CT, to look at the size of the ostium naturale. So in these cases, sometimes we use some nose drops before doing the surgery to make sure that we have a very good airflow going through the ostium naturale, but we don't extend it surgically before doing sinus grafting procedures. So another question by Mr. Gutsaliuk: do you use the sinus implant stabilizers in your practice? I know that these implant stabilizers, that they are existing, we don't use it in our clinic. It might be an interesting aspect to stabilize a non-primary stable implant when we place more than one implant by performing a connection to the adjacent implant. But we don't use it, and when we see that there's no primary stability, we would always go for some two-stage surgery, that we first reconstruct the sinus, the bone in the sinus, and then we are placing the implants. So in these cases, for example, with the remaining bone height of about 2 millimeters in a 7 region, we would first do the sinus grafting instead of using implant stabilizers. Another question: how does osteotomy preparation in sinus augmented bone compare with non-augmented bone? A question by Mr. or Mrs. Raichura. I think there are some studies about this. We see implant survival rate of about 97 to 99% in non-augmented bone. When we compare it with some sinus grafting study, they go up to 96, also 98% of implant survival rate. A lot of studies are showing 100% implant survival rate. So therefore, I think in this specific indication, where we have very good prerequisites for bone formation, and when we're using a two-time approach, that we first graft the sinus and then place the implant, we can get almost same results than for the non-augmented bone. Interestingly, there's one study published comparing autogenous bone and a bovine bone substitute material in the sinus, and what they found was that the grafted sinuses with bovine bone material showed a higher implant survival rate than the sites that were grafted with autogenous bone. This is also an effect, from my point of view, that we see a very long lasting volume stability of the bone substitute material, so it has a more stabilizing effect on the grafted site. Another question: your opinion and your experience for cancer formation after bone grafting. Thank you. It's a question of Gatos. I don't think that there is any tumor related to the bone grafting procedures. We have some considerations about this when we're using the BMPs. This is the reason that, for example, in Germany, you can't get the infuse, the BMP2, in combination with the collagen sponge, because the Germans are a little bit afraid of inducing some bone tumors. But for all the other techniques, so cancer formation is a result of mutations. So no bone substitute material, from my point of view, is able to induce some bone cell mutations. So we go on. What is the shortest time waiting before implantation after augmentation? That depends on the area where you want to place the implants. For a normal sinus grafting procedure with a very low remaining bone height, it's about 6 months. When we have a remaining bone height of about 4 to 5 millimeters, can be easily decreased to 4 months, because we expect good bone quality from the remaining bone before doing the sinus grafting procedure. So the shortest time can be also influenced by the implant you're using. If you use a hydrophilic implant, for example, you might reduce the loading time. When we perform a lateral augmentation with some autogenous bone, we wait for about 4 months. So after 4 months after lateral augmentation, 3 to 4 months sometimes, and after 6 months after vertical augmentation. Okay, another question by Mr. Os Allen. What is the pericardium membrane made of? Will it resorb later on? Of course it will resorb. It's a natural collagen. It's based on the porcine pericardium, so that is covering the heart. It will resorb within, let's say, 4 to 6 months in human beings. We performed a lot of studies in animal settings and also in human beings with this membrane, and we think that this membrane, even if it's very thin, because of its three-dimensional pattern of the collagen structures, it has a barrier time that is quite enough for all augmentation procedures. So no need anymore for double layer techniques as known for the biogut membrane, for example. Very easy handling. You can apply it, you can remove it, even if it's rehydrated, you can trim it again, place it again back. So this pericardium membrane was a very nice introduction by botiss for smaller and also for larger augmentation areas. Next question. Diego Navas, do you use the procedure for botiss to prepare the bone by a CAD-CAM? So in our department, we are using a lot of hip grafts for three-dimensional augmentation of the anti-maxilla, of the anti-mandible. So because we are maxillofacial surgeons, we are quite easy getting access to as much bone as we want to. So therefore, we're not using the bone builder system that often. Nevertheless, if you work in a practice, it is a very nice and interesting technique to vertically and horizontally reconstruct the deficient alveolar process without the risk of contamination of the graft, without the risk of very long operation times. So it makes it much easier and much faster if you get a three-dimensionally pre-designed bone block for your specific patients. Then, do you have any experience of mixing bone substitutes with autogenous platelet-derived factors, I think like PRF? A question by Alessandro Susino. We have performed a lot of cases with PRF. We have this PRF machine. I think it's supporting the application of the material, and also by application of the fibrin membrane, it might support the soft tissue healing as well. Just for practical things, we don't use it anymore, but for a general practitioner, I think it's a quite nice and helpful device to support the outcome. So I would recommend to use PRF as well for vertical horizontal augmentation. You can easily mix it with the bone substitute material. You can form like a tortilla for better application. So it might be a useful tool for any kind of grafting procedure. One of the last questions is from Dr. Radkov. What do you prefer, placing implants by time of surgery or after 6 months? For us, it's the case that we are working here in a big maxillofacial surgery department. So if we look at the patients that we are treating, they are mainly having severe resorptions of the maxilla and the mandible. So therefore, it's more likely that we are placing implants delayed after 6 months than placing it in progress of the sinus floor elevation. Nevertheless, if you have a system that allows for good primary stability, even if you have 4 millimeters of bone height, there's no negative aspect of placing the implant at the same stage like the sinus grafting procedure. So for a general practitioner, it might be for his patients a very good opportunity to place the implant at the same stage with the sinus grafting. Another question: how do you manage nose bleeding post-sinus augmentation? A question by Vijay Raichura. We're performing a lot of sinus grafting procedures, and massive nose bleeding was not seen within the last 7 years. So of course we have the possibility to put some tissue into the nose to stop it. That would be one option, but we never had to do it. Sometimes during the surgery, what you can see is that there's an artery, a little artery inside the bone, or even on the inside of the bone, that needs to be cut. So then sometimes you see that there's some blood coming out of it. So in our department we are having this electric devices to make sure that we can coagulate the arteries, so we don't see any big problem when we perform it without having the access to this bipole device. Then we just wait. Sometimes we can easily block it, that you use some respiratorium, for example. You hold it at the perforation where the artery is coming out, and you just, with a little hammer technique, you can block the area, and then you can support the blood clot formation. If you're not able to stop it, just put some cotton in there and wait. Put some local anesthesia on top of it, because our local anesthesias are containing some adrenaline. So therefore, it will lead to the effect that we have a contraction of the artery, and within 3 minutes, from my point of view, almost all of the bleedings in the face area will just stop by itself. So no big problem when you see a bleeding coming out of this little artery. And then the last question that was not answered yet, a new question from Andre Sarafinan, Finchan. After how much time you can make a second sinus floor augmentation after infection, graft material, and evacuation of the graft? So this depends on the patient, of course, on the intensity of the inflammation. We would recommend, when you have a perforation of this Schneider membrane without any infection, wait at least 3 months. That is healed completely. Sometimes when you do a second stage surgery, it's a little bit tricky to do the preparation, because you have a connection or a direct adherence of the sinus cavity and the periosteum outside, because you have performed a lateral approach already. So then you need to perform a sharp preparation of the Schneiderian membrane. After 3 months, you can redo the operation. When we have a massive inflammation, we would, if it's possible, prefer waiting 6 months. So after 6 months, we perform another three-dimensional X-ray. We evaluate the bone quality in this area. We also evaluate the thickness of the Schneiderian membrane. Sometimes if you see that the Schneiderian membrane is a little bit thicker than expected, like 3 or 4 millimeters, this is not a big thing. So you can easily perform a sinus grafting procedure, even if you have a remaining swelling of the Schneiderian membrane. But if you see that there's still, the entire sinus is filled with some granulation tissue, probably you first have to, if you know how to do it, you have to do the operation of the sinus cavity, or if you don't know how to do it, just send the patient to an ENT surgeon to make sure that in this sinus area the conditions are good enough to perform the sinus grafting procedures. If you have a massive inflammation, of course, it will take up to 6 months until you get this good quality before redoing the grafting procedure. Okay, so I think I've answered all the questions. Thank you very much for listening. Thank you very much for watching my presentation. I hope that I could give you some new impressions probably for your daily practical work, and with different aspects of this presentation we can make sure that we can treat our patients in a very safe and very predictable way for reconstruct the vertical bone height in the posterior maxilla. Thank you very much.
Thank you very much, Dr. Rothamel, for sharing your lecture and your insightful information with us. We would also like to thank botiss for making this online course possible, and thank you, our wonderful audience, for your interest and participation. The recording will be posted online within the next 48 hours. You will receive an email notification with a link to the recording. Further questions regarding the lecture today may be submitted directly on the website on the courses page under the Ask the Expert tab. So please go ahead and submit your questions, and Dr. Rothamel will be sure to get back to you as soon as possible. Please be sure to visit botiss Academy focused educational platform www.botissacademy.com and keep an eye out for our growing schedule of online courses. Thank you again to all, take care and goodbye.